Thank you, Claudia, for the intros, and thanks to the Epicenter for the invite for me to be part of this very important day. We turn now to tuberculosis. As Claudia has said, and as some of us may know, TB is one of the global threats that we are dealing with. An infectious killer that is only second to what has been documented to COVID-19. If COVID-19 was not there, then it is the first killer of what we are seeing globally. In the last global TB report, we noted that over 10 million people fell ill with this disease. And these included about 12% children and 55% were men. Over a long time, we have been wondering why men. But also, we know that it is difficult to make a diagnosis of TB. So in that year, the coverage for TB, especially among the people that developed drug-resistant TB, who were about 400,000, only 40% reached care, which leaves a very big gap. But I also know that in the other susceptible TB patients, still a number of countries are struggling to identify the people who fall ill with TB. So in this session, we have very good work that Epicenter has done in a number of countries. Following the WHO release of the new diagnostic algorithm for TB among children, there is some work that Epicenter is doing to test whether this is feasible, is acceptable, and we'll be having some of these insights this afternoon. But we also know that the treatment for TB generally is complicated, but when it comes to MDR TB, it is even much worse with many side effects, but also further more difficult to treat when it comes to children with the formulations available and so on. So in this area also, we have very interesting findings, some of which are from clinical trials, but also other findings that we'll be looking at during the sessions. So with us, we have very informed presenters, and my colleague is going to come and let us know more about them and also invite the first presenter. Thank you.
Thanks very much, Dr. Stavia. So just before presenting our next two researchers, I'm just going to give you a bit of background about the study that they're working on, because it's part of a bigger project that you may or may not have heard about called TACTIC. So TACTIC stands for Test, Avoid, Cure TB in Children. And it's a multi-section, multi-dimensional project. It's funded by the TIC, and it's about helping in three different areas to improve the management of TB in children. So the first area is implementation. So implementing new recommendations from WHO. We're lucky we have 3 areas of new recommendations from WHO to improve the management of children with TB. First of all, on the diagnosis, treatment decision algorithms to help clinicians make decisions using clinical parameters, getting children on treatment faster and avoiding mortality. Treatment, so shorter treatments for non-severe drug-susceptible TB and maybe soon for drug-resistant TB. We'll hear more about that later. And prevention, so trying to get that prevention out there and rolling out these shorter treatments for prevention. So all of these axes, they are interlinked. They feed into each other. To do the implementation, we need to do advocacy. So that's the third act, advocacy for implementation, but also advocacy for better tools for the management of TB in children. So the study that you're going to hear about today is part of the operational research, but is feeding into the implementation. It's operational research on the implementation and feeding back the lessons learned, documenting the impact, and it's real-time impact. So these results are right now impacting how we're going to continue with the implementation, scale up within countries and in different countries. So you're lucky because these are the first results to be presented from this study, the PED algorithm study, which is a mixed method study. We have the validation of the algorithms, but also feasibility and acceptability of these treatment decision algorithms. So the two presenters are Sophia Payot. So Sophia is a social psychologist and collaborating researcher in the STIM-NUT study, which is a stimulation psychosocial on nutrition Coachella study, and in the TB algo study that I just explained. And she's a member of the Mixed Method Research Technical Support Group at Epicentre. And Julia Scarpa is a pediatric nurse and researcher working at Epicentre and at the Institute of Tropical Medicine in Antwerp, in Belgium, and she uses mixed methods and participatory approaches in the field of maternal child health, nutrition, and climate change. So please welcome them to the podium.
Donc, bonjour à toutes et à tous. Je vous propose de commencer.
Good afternoon. I'll start with a few words about the backdrop to show you where our research stands.
Partons d'un premier constat.
Now, the first thing is that TB in children is often underdiagnosed. We know that about 60% of children with TB are not diagnosed, and that 96% of children who die with TB were not treated. So, in order to face this, the WHO has developed algorithms in order to provide more structured guidance for health workers and in order to improve TB diagnosis in children. As you can see here, on the left-hand side is algorithm A for entities with X-ray, and on the right is algorithm B for those who do not have access to X-ray. The algorithms are cards on which the health workers, doctors and nurses, on top of the diagnosis investigations, can tick the boxes of the symptoms that they have observed during the clinical examination, and in the end they get a score which will make it possible for them to decide about the prescription of anti-TB or any other type of treatment. MSF has developed a large project called TACTIC. As Kathy said, it means Test, Avoid and Cure TB in Children, and this aims at improving the diagnosis and the management of TB in children in several countries via support to field teams and advocacy for the implementation of algorithms, but also through the implementation of operational research. And that's the objective that the TB AlgoPED study tried to achieve. The TB AlgoPED study is made up of three parts. You have a prospective study that looks at an assessment of diagnostic performance. The second one is an analysis of routine program data, and there is a mixed method study in the middle that looks at the feasibility and acceptability of the algorithms. Today, we are going to focus only on this part here. In this feasibility and acceptability study, we have three main objectives. The first one is to identify these contextual and socio-cultural factors that could influence the algorithm adoption and the diagnostic process. The second one is to understand health workers, patients and caregivers' perspectives on the TB treatment decision algorithms, and to analyze the evolution of practices and potential changes led by the implementation. This feasibility and acceptability study will be carried out in three countries, Guinea, Niger, and Uganda, which are currently implementing the algorithms.
Elle combine
It's a combination of several data collection methods, interviews, focus groups, observations, which are done at 3 key moments of the implementation process. At the onset of implementation, after 6 months of implementation, and within 24 months of implementation.
Enfin, cette étude
And this study
cible une population
targets a population made up of health workers, physicians, nurses, caregivers of children presenting with TB symptoms, and key informants.
Donc pour aujourd'hui, nous allons
And today we are going to present the preliminary results of the thematic and critical discourse analysis. We carried out 45 interviews with health workers, doctors and nurses who attended the algorithm training. The interviews were carried out in Niger, Guinea and Uganda at the beginning of the implementation process. Now let's look at a few data about the context before implementation so that you understand the barriers to TB diagnosis. First of all, we asked health workers to describe the typical path of asymptomatic children and to explain what were the obstacles that they have identified. In a few words, the health workers consider that the main difficulty for them is to diagnose children which come to see them with a very deteriorated health status. And this is illustrated here. You have to read this from left to right. So, the health workers explain that some factors in the community, that's bottom left here, like the lack of resources, the lack of knowledge, the stigma, and the difficult access to health care will lead the families to first resort to self-medication or traditional medicine. Then, once they get to the healthcare center, that's the middle of the blue line here, there are other obstacles which make the diagnosis more difficult, such as the lack of knowledge of the staff, the fact that also sometimes you have to negotiate with the parents to be able to carry out the tests or investigations on their children. And also, some mention the fact that they have a shortage of test kits and or X-rays, or the X-ray machines are broken down, so they have to refer the kids and their families to another healthcare center, and this might actually lose them to follow up. So to summarize, there are a certain number of constraints in the community and in the families and in the healthcare centers. It's therefore a very difficult context in which the algorithms are currently being implemented. Let's now look at results about the health workers' attitudes. In general, in all 3 countries, we have seen very positive attitudes because the participants consider that the algorithms meet a real need which they have in their working context, and because they make it easier to make a decision. Therefore, healthcare workers feel that they are more empowered, more autonomous, because they don't need to rely so much on X-ray. And also, some healthcare workers also say that the algorithm enables them to save time during the consultations with patients. But then, for some agents, the algorithms being integrated into their daily work is a challenge because it's more work for them to perform on top of what they already have to do. And this illustrates the perceived efficiency of algorithms, which will now make it possible for them to better differentiate TB symptoms from other diseases and to therefore have a better rational diagnosis. And now let's look at the results coming from the interviews with nurses in Niger. We started the implementation a little bit sooner than in other countries, and so we had a little bit more perspective when we conducted the interviews. The nurses who use the algorithms claim that they are very useful because they make it easier to identify TB symptoms, and their use makes the clinical reasoning more legitimate, especially thanks to the scoring system, because actually they can objectivize their interpretations and their conclusions.
Par ailleurs, certains expliquent
However,
que les algorithmes contribuent
also, some say that the algorithms
d'autonomie
help
et
them
d'efficacité
feel
dans leur
more
travail.
empowered and
En
more
revanche,
efficient in their
certains
work.
infirmiers
However,
avaient
some
reçu la formation
nurses
aux
who
algorithmes, mais n'ayant
received
pas été
the
impliqués
algorithm
dans
training
leur
but who were not
utilisation
involved in their
expriment un
use
sentiment d'exclusion
feel
et
the
de
feeling of exclusion
pas à
and
l'égard
of
des
negative
algorithmes,
attitudes,
mais à l'égard
not
des
towards the
gens
algorithms themselves, but towards the implementation process.
Résumer avec ces deux citations,
And
que
we can
l'adoption
summarize
des
this with those
algorithmes
two
semble apporter des
quotations.
effets bénéfiques
The
au
algorithm
niveau du
seems to
statut
have
et du rôle
positive
des
effects in terms of the
infirmiers.
status and role of nurses, which is illustrated by this
Cette première
verbatim
citation,
where the
l'infirmière
nurse
dit,
says,
maintenant,
now
avec
with
cet
this
algorithme,
algorithm,
on a
we
appris la
can
détection.
actually
Vraiment,
screen
nous,
the
c'est
people,
une fierté pour nous.
and we are proud of this.
Et par ailleurs,
And
les infirmiers qui n'ont pas été
for the nurses which were not included, you see that they would like to be included. As you see in this quotation, it says, now it's only the doctors who fill in the forms. If we were properly trained, who could fill in those forms? Doctors are not the only ones working here. We are always in contact with these children. It means that implementing the algorithms seems to be a good opportunity for nurses to improve their working practices and therefore to become more proactive in the diagnosis of asymptomatic children. Conclusions. This analysis enabled us to identify different types of obstacles that give us information about the very difficult context in which we implement the algorithms. The discourse analysis shows, in general, a positive attitude to the implementation of algorithms because they consider them to be necessary to help them face the difficulties in their work environment. The implementation and use of algorithms empowers nurses. But these are only preliminary results, and they also illustrate that the expression of positive attitudes does not mean a change in work practices, because we have also identified challenges related to the excess of work or the feeling that they did not feel involved or that they lacked knowledge. So these results also illustrate the need to become more interested in the context of the health structures. For example, the definition of roles of agents and the distribution of work in order to make sure that these innovative tools will be accepted and adopted. And the next phases of our study on the feasibility and acceptability will aim at exploring how the algorithms are perceived and adopted in the long run. Thank you for your attention.
Thank you. We have our next presenter, Matthew Bastard. Matthew Bastard is a statistician in the TB Monitoring and Evaluation and Strategic Information Unit of the Global Tuberculosis Program in the World Health Organization, where he's supporting the work on TB burden estimation for publication in the Global TB Report and providing technical support to countries for the analysis of national surveys. Before joining WHO in 2022, Matthew worked for 12 years with Epicenter and Medicines Sans Frontiers, supporting operations research TB projects in Eastern Europe, Sub-Saharan Africa, and Asia. Matthew will be presenting to us this afternoon treatment of children and adolescents with MDR RR regimens containing bedaquiline, delamanid, results of a study from the NTB observation study. Welcome, Matthias.
Thank you, Dr. Stavia. Wow, c'était une introduction un peu qui met la pression.
Thank you, Doctor. Well, this introduction put some pressure on me. I'm most happy to be here. Like Dr. Stavia said, I worked for 2 years at Epicenter, and now that I'm gone, finally they invited me to make a presentation again. I'm most happy about that. I'll be speaking in English.
Donc, je vais présenter.
I didn't realize we could be speaking in French, but I'll present in English.
I'm going to present this study from the NTB observational study, which will talk about the treatment of children and adolescents with multi-drug resistant and rifampicin resistant TB regimens containing bedaquiline and delamanid. So, until recently, the treatment of MDR and RRTB was long, toxic, and poorly effective. However, in 2015, 2 new drugs were available to treat MDR and RRTB, and these drugs are bedaquiline and delamanid. And the NTB project, which was launched in 2015, was launched and funded by Unitaid and had 5 main goals. And one of them won the observational study to document the expanded use of bedaquiline and delamanid in 17 countries. And one of the other goals was to implement clinical trials to find simpler, less toxic, and shorter regimens. And Mylène will talk about this after this presentation. So just to give a bit of background on the NTB observational study, if you need additional background, this was one of the largest multi-country prospective observational study at that time, where patients were treated for MDR-TB with bedaquiline and delamanid, as long with other drugs. So it was implemented in 17 countries with 3 different partners, including MSF, IRD, and Partner in Health. And it was funded by Unitaid. And the patients were included between April 2015 and September 2018. So as we have heard this morning and again just before this presentation, children and adolescents with TB and also with MDR and RRTB are often underdiagnosed and undertreated. There are limited data that exist on the treatment of children and adolescents with bedaquiline and delamanid. And one of the main reasons for this is that because they are not enrolled in the clinical trials usually, and that is why the observational studies are essential. And with the NTB observational study, it gave us one unique opportunity to assess the effectiveness and the safety of MDR and RRTB regimens containing bedaquiline and delamanid among children and adolescents. So the population in this study consisted of children and adolescents of 19 years old and less who initiated MDR and RRTB long and individualized treatment regimens that contain bedaquiline or delamanid together with other drugs between 2015 and 2018. And in this presentation, I will first describe the cohort of included children, talk about the end of treatment outcomes, describe also a bit of the safety of these regimens, which consist of the frequency and the outcomes of the main adverse events of special interest. Those are predefined sets of adverse events and serious adverse events of interest that occurred at a clinically relevant severity level, such, for example, as acute renal failure, electrolyte depletion, hepatotoxicity, hearing loss, hypothyroidism, myelosuppression, optic neuritis, peripheral neuropathy, and QT prolongation. So one of the very important aspects of the NTB observational study is the unique safety monitoring data collection that was put in place. There was a systematic collection of the safety data, including the serious adverse events, the adverse events of special interest, and the adverse events of clinical significance. And in addition to that, all the serious adverse events were also reported to the national authorities and to the MSF pharmacovigilance unit that was built through the NTB project in Geneva. So this cohort consisted of 190 children and adolescents in 14 countries. Most of them were aged between 15 and 19 for about 87%. 64% of them were female. And as you can see in the bottom of this table, it was a quite sick cohort of patients, with half of them resistant to fluoroquinolone drugs. 71% of them have lung cavities or bilateral disease on the chest X-ray. And about 70% of them had history of treatment with second-line TB drugs. So that's a very sick cohort of MDR TB patients, children. So at treatment start, all the children and adolescents received one of the 2 drugs of interest, bedaquiline or delamanid, or both bedaquiline and delamanid. So bedaquiline was prescribed in regimens in 51% of the children, and 39% of them received a regimens containing bedaquiline, and 10% of the children and adolescents received a regimen containing both bedaquiline and delamanid. So as I said, this is a full regimen, so there are also other drugs prescribed with bedaquiline and delamanid. So in addition to these drugs, they receive another 5 drugs in median. And these are the most prescribed drugs in the MDR regimen. So the main prescribed drugs was linezolid for about 80% of the children and adolescents, followed by pyrazinamide, cycloserine, quinolones, and clofazimines for about 70%. And at the very bottom of this graph, you can see that still 35% of the children and adolescents received injectable drugs at that time, where they were still part of the standard of care. So I will present now about the end of treatment outcomes of this cohort. So there was a very high successful treatment outcome in this cohort. About 85% of the children were cured or completed treatment in a median time of 21 months. 13% of them experienced an unsuccessful treatment outcome, so 5% died, 4% were lost to follow-up, and 4% had also a treatment failure. And out of the 10 deaths that were reported in this cohort, 6 of them were due to TB, or TB was a contributing cause. So I will present now some of the safety results, and I will just present the main adverse events of special interest that occur in the treatment. So the first and the main adverse event that occur in these patients were peripheral neuropathy that occurred in 16% of the children and adolescents. And you can see on the pie chart, the yellow part is showing that in 54% of the case, the episodes resolved without sequelae, and for 35% of the case, the episodes resolved but with sequelae. Then it's followed by electrolyte depletion, which happened in 15% of the children. And as you can see, in most of the episodes resolved without sequelae at the time of the reporting. And the last one, the third one, which occurred in 7% of the children, was hearing loss, which are mainly due to the injectable drugs. And here we can see that only a third of these episodes resolved without sequelae, although another third resolved but with sequelae. And for 1 children, the episode was unresolved. And finally, since this was one of the main concerns at the time of these new drugs was prescribed, we can see that we had only 2 episodes of QT prolongation in this cohort of children and adolescents, so a relatively low number, which is about 1% of the cohort. And in these 2 episodes were resolved without sequelae. So what we can see from this study is that the treatment with MDR and our TB with bedaquiline and delamanid is effective and well tolerated among children and adolescents. The adverse events of special interest were not very common in this cohort, although there was one small limitation, is that the children under 5 were underrepresented here, and this is mainly due to the barriers to treatment decision, and including uncommon bacteriological confirmation for children and adolescents. And as I said before, there is very few data on the safety on children available, usually because they are not enrolled in the clinical trials. So that highlights again the importance of the NTB data in the TB observational study, which was one of the first cohorts, actually the first cohort of children and adolescents receiving bedaquiline and delamanid as part of their regimen, with especially a very detailed follow-up and adverse event monitoring. So one last slide to say that all this data, mainly on safety, contributed to the updated WHO guideline in 2020 and 2022. And now the recommendation is that there is no barrier to use this drug in shorter regimens in children. The drugs are now recommended at all ages. There are existing child-friendly formulations, and there are no major safety issues. So the message here is really that all oral regimens should be scaled up as recommended by the WHO for these age groups, such as, for example, at the NTB regimen that Mylène will talk a bit after. So just a few acknowledgements here. All the patients, the NTB teams, all the national TB programs who have collaborated here, the central research team, the analysis team, and Cathy here, and Elena also, who is in the room, which were 7 years of great work with you, and all the NTB team in general. Thank you.
Thanks very much, Matthew. Okay, so our last speaker is Mylène Gouillou. Mylène is a biostatistician in the research department of Epicentre. since 2019, and currently she's the operational statistician for the NTB trials, and she has international experience in the analysis of epidemiological studies and clinical trials, and particular focus on infectious diseases and international health. So welcome to the podium, Mayden.
Hi everyone, good afternoon. I will now present some results of the NTB clinical trial, which is part of the NTB project, which was presented by Mathieu just before. And more precisely, I will present the results in key drug-resistant TB patient subgroups. So a bit of a background. Back in 2015, multi-drug-resistant tuberculosis represented nearly 500,000 of cases and was responsible of 190,000 deaths per year. At that time, the treatment was long, between 18 to 24 months. It was toxic, complex, required taking a big amount of pills every day, including injectable from 6 to 8 months. And it was expensive, and on top of that, it was poorly effective with a success efficacy ranging from 50 to 60%. So the arrival on the market of bedaquiline and delamanid a few years before offered the opportunity to change this treatment to all oral and more user-friendly regimen. So that's when the NTB project, that includes the clinical trial, was implemented with the aim to improve treatment of MDR-TB and find better, shorter, and less toxic regimen. So the NTB trial, so it was a randomized, controlled, open-label, non-inferiority phase 3 trial that included participants of 15 years old with rifampicin-resistant, fluoroquinolone susceptible pulmonary TB. The objective was to compare each of the 5 experimental regimens to the control, and the treatment duration in the experimental regimen was 9 months, while it was approximately 18 months in the control arm. Patients were followed for at least 73 weeks, which is 17 months, and up to 104 weeks, which is 24 months. And the primary endpoint was a favorable outcome at week 73. So all 5 NTB experimental regimens that are presented here, they all had at least one new drug, being bedaquiline or delamanid, one repurposed drug being clofazimine or linezolid, all had fluoroquinolone, which is moxifloxacin or levofloxacin, and all received pyrazinamide. The control arm was the current WHO standard of care, so it may contain all the drugs that were currently recommended by WHO, and in particular, it may contain the new and repurposed drugs that were composing the experimental regimen. Now the NTB clinical trial is terminated and the results have been presented recently, so we will quickly go through those main results, but the objective of the subgroup analysis that I'm presenting today was to explore the efficacy result of the NTB trial in key subgroups. Do these results hold? Can we find any signals in some specific populations? And also, because several short regimens are now available, can we help clinicians to make the choice between the different NTB regimens for the patient with a more difficult to treat form of disease? So for the population, we were interested in baseline characteristics that could influence the choice or the success of any experimental regimen. And the risk factors were selected from the literature, keeping the ones that were shown in previous study to potentially affect or change the effect of shorter regimen compared to longer ones. So in this way, we kept the following baseline characteristics: HIV co-infection, low BMI, diabetes, and severe disease. In terms of method, we look at the proportion of favorable outcome at week 73 in all the participants who had this characteristic, and also the participants who did not have these characteristics in all experimental arm and in the control arm. The risk difference was calculated as a difference of proportion of favorable outcome between each experimental arm and the control arm, along with the 95% confidence interval using a Poisson regression model with robust standard errors. The population that we used for this analysis was the modified intent to treat, or MITT population, which is a population that contained all the randomized participants who received at least one dose of study treatment, who had the culture positive, who were shown to be resistant to rifampicin, but were not known to be resistant to any experimental arm drugs, excluding pyrazinamide. We will focus in this analysis on the arms that were found to be non-inferior in the main study, and we precise here that this study has to be seen as an exploratory analysis, as the study was not powered and not designed for this comparison. Okay, so the patients were recruited in 12 sites in the NTB clinical trial over 7 countries all over the world, as you can see here on the map. The 754 patients were randomized as initially planned between February 2017 until October 2021. And the database was locked and the analysis started in June 2023, so last year. Here you can see the proportion of favorable outcome at week 73 in all arms. So the main thing that we see, it's the high proportion of favorable outcome in all arms, ranging from 78.8% to 90.4%. And an important thing to note here also is the high proportion also of favorable outcome in the control arm, which is performing very well with over 80% of successful outcome. Three arms in the NTB clinical trials, so NTB 1, 2, and 3, were shown to be non-inferior in all analyses, and NTB 2 was even superior to the control. Right. So now we will look at the results in the subgroup of interest, and all subgroups will be presented in the same way, so on a forest plot like this. So for each arms that were shown to be non-inferior in the main study, NTB 1, 2, and 3, we present on the first line the result of the overall population, and then for each subgroup of interest, for each category, we'll present all the categories of the subgroup, with the one category of interest being highlighted in blue, like here you can see the HIV positive, for example. Then we have the number and the proportion of favorable outcome in the experimental arm first, and then in the control. And finally, on the right, you can see the risk difference represented as a square, along with its 95% confidence interval as a bar. The vertical line represents a risk difference of 0, so everything which is on the right of this line favors the experimental arm, while everything on the left favors the control arm. So for HIV positive, we see that in arm 1 and 2, result in HIV positive seems consistent with the overall result, while in arm 3, the effect seems to be different in HIV positive compared to the overall population. It favors the control arm. It's on the left of the vertical line. And it also appears to be different from the HIV group that were receiving NTB1 and NTB2. Then with our definition of disease severity, we see no difference in the participant with a more severe disease from the overall population in the 3 arms. The general findings of NTB still remain valid in this population, and we cannot see any difference between the three groups for participants with a severe disease. In the case of low BMI, we see that the 3 arms seems to favor the control arm rather than the experimental arm, which was not the case in the overall population, and we don't see any difference between the 3 arms. If we finally look at the patient with diabetes, the results seem to suggest also differences in treatment effect from the overall population, but in favor this time of the experimental arm. So even if the confidence intervals are wide, the direction remains the same from the overall population. And we don't see any difference between the 3 arms. So as a conclusion, We did not detect any signal in patients with severe disease or diabetes, so it seems reasonable to use NTB 1, 2, or 3 in these populations. While we detected a first signal in HIV-infected patient in arm 3, so it might be preferable to use NTB 1 or 2 over NTB 3 in HIV positive. And then we detected also a second signal in patients with low BMI in all 3 arms. So for these patients, best treatment are still unclear, and maybe longer or regimen with more drugs could achieve better results. So we think that this first element can be already included in the discussion with patients to inform and guide the choice of treatment. And of course, further evidence and additional research are needed to confirm or not these signals, and also to increase knowledge to get clinicians on the choice of regimen for this subgroup of patients. We would like to thank all the people who have been involved in the NTB clinical project. So as you see, it's a lot of people, a lot of partners. And we also would like to thank all the participants, the team on site, the central team, which are a lot of people that are here now. And thank you, everyone, for your attention.
Another round of applause for our presenters. It is now time for reflection, questions, comments about the 3 presentations that we have had. You have some questions?
Okay, while we're waiting for some questions from the people in the room, we have one question online from Jemayo Shabada. Thank you. Vous devez mener des études ethnographiques pour comprendre pourquoi il existe des obstacles lors de l'examen.
How can we understand why there are barriers to examining children or screening children for TB? Couldn't hear that, sorry.
Okay, thank you so much for the question. I agree for sure with the ethnographic studies. We are going to understand more, but we had also some time issues, so we didn't have also fundings and time for doing ethnographic studies, which usually requires more first trained field workers and researchers, but also longer term. So that's why we didn't conduct, and instead we use other methods. Thanks.
Any other comment from the? Yes, here.
Oui, merci beaucoup pour cette très bonne présentation.
Many thanks for those great presentations. I have a question
Les low BMI.
About the low body mass index patients. So the 3 treatments are less good than the control treatment. So maybe the low BMI patients are the most severely affected MDR-TB under very severe forms. So it's really a problem that the 3 regimens don't work as well as the control treatment that is very long, or maybe we should feed them and fatten them with nutrients, with the right nutrients. How do you account for that? Thank you for the question. Yeah, all the subgroups we considered, we tried to pick the most severe forms in each group, so low BMI is part of that. Then, well, all those are exploratory studies, right? So we cannot reach a final conclusion on that. And that's why we say in our conclusion that we do see some signals, particularly in the group of low BMI patients. We need further explorations, more data, but we compared with other studies.
qui n'avaient pas regardé à ces données en fait. Donc,
that didn't look at all into that aspect.
c'est juste un signal, il faut qu'on...
So it's merely a signal and we have to dig further. I work in the same team. I'd like to add, yeah, it's something we found that we didn't expect necessarily. You can account for it by the severity of the condition, of the disease, but we didn't see the signals of that. We may imagine that the dosage for those patients with very low BMI were not well adjusted. It was complicated to identify the best dosage for low-weight patients. It might be an interesting signal. That's why we say be careful and think twice. Is it better to have an individualized treatment for those patients, or it's not a matter of treatment, but duration of the treatment? So maybe in those low BMI patients, we may prolong the treatment. So maybe it's not just anti-B, you know, we compare an 18-month treatment with a 9-month treatment. We might find the same signals in treatments of 6 to 8 months. We're lacking data still.
Merci beaucoup.
Thank you. I have a question about what comes next. Have you done risk factor analysis with adjustment? Often a low BMI is related to HIV. It's a mortality factor. And then the severity of the disease also well, positive results. I mean, many things overlap here. So does BMI appear as a risk factor independently from the severity risks with HIV or other diseases? Yes, we did do adjusted analysis. We did include the BMI component in our adjusted analysis, but I forgot the result. Yeah, it was not statistically significant, so we did it.
Il ne reste pas dans le modèle final.
But we didn't. It didn't appear as being significant in the final model.
Okay, is there any other questions in the room or online? I don't think so. Yes, great.
Thanks, Johanna, paediatrician with MSF. It's just a comment on the simplified algorithms implementation and the role of task shifting. I just wanted to bring up that often we'll see, it's not just about putting kids on TB treatment, it's about putting them on TB treatment appropriately. And so what we often see is that they're put on treatment and then all other treatments stop. And so I think there's a limit to how much we can simplify and task shift.
Maybe I can just comment on that. Yeah, thanks, Joanna, for that comment. I think it's important to remember there's two parts to using an algorithm. So the first part is identifying which children have presumptive TB. So that means symptoms of TB. And in fact, that is the hardest bit. And it's there where nurses, I think, play an enormous role and other health workers in eliciting those symptoms because they spend more time with people and they are more likely to get the long story, which, you know, sometimes we just get the standard story, which sometimes you don't elicit those long-term symptoms of TB, cough for a long time or fever for a long time, weight loss, and especially the contact with a previous TB case, which usually takes a little bit of discussion before you get that information. So the hardest thing I think about diagnosing TB is eliciting those symptoms and saying, now I'm going to think TB. Once you think TB, it gets a whole lot easier. And that's when you start using that algorithm. So yeah, I think there's a role for everybody to play, and the algorithm really helps those clinicians have a bit more confidence once they've thought about TB. And I think they're going to be, and we've already seen in the field a big increase in the number of children started on TB treatment. So make sure you've got enough TB treatment in the cupboard when you start them. Thank you.
Daniel is asking why did malnutrition do worst with the new drug treatments? Might this be linked to immune reconstitution syndrome?
Oui, merci pour la question. Ouais, je vois que ça, quelque chose a été.
No, thank you very much for this question.
En fait, on peut pas trop. Effectivement, on est vraiment dans l'interprétation des résultats, en sachant que c'est une analyse de sous-groupe.
Now, this is an exploratory subgroup analysis based on a small sample. So you could imagine that there's indeed something, and it could be associated with immune factors or the regimen given during treatment, because we didn't adjust for other associated factors for low BMI patients. So that might play a role. And as Mylène said, in the main analysis, we adjusted in 2 cases, in 2 analyses, with a model that was pre-established and then statistically based on associated factors. And in the general population, the adjusted and non-adjusted analyses are very robust. So our results are fairly robust. And we try to have some complementary elements to guide clinicians. And I think that we now have a clear answer for this population of patients who are malnourished.
Okay, thanks very much. If there's no other questions online or in the room, I'll just wrap up quickly. So I think that last point was very interesting on the nutrition. As I mentioned before, nutrition and TB are very closely linked. We know that low BMI is a risk factor for poor outcomes for TB. And we also know that the biggest impact on the epidemiology of TB in the world over the centuries has been the increase in the socioeconomic level of countries. That had much more impact in reducing TB than treatment and diagnosis ever did. And we're getting more and more evidence that nutrition is an important treatment. So WHO is currently revising the TB and nutrition guidelines, so let's keep an eye out for that. So I think these 3 presentations from our 4 presenters were fantastic, and they represent long years of work, not just something that happened recently, and real big effort from everybody. So thank you very much for those amazing results. And I think we can also see some progress. I think it's great to see now we have shorter treatments, both for non-severe drug-susceptible TB in children, but also shorter treatments for drug-resistant TB, including children, because even though children were not in the clinical trial, children are eligible for these regimens because they can take all of these drugs, because we've looked at them in the observational study. So we're very glad to see that progression. And so all we need to do to get them those treatments now is to diagnose them. So we're working on that. Let's all work together. And I think TACTIC is there to support all the teams in that implementation. And the TACTIC team, Danielle and Jocelyn, are here today, so feel free to go and speak to them. And thanks very much, everybody, for your participation and for listening. Let's give another round of applause for our presenters.